this video we'll do an exam review on optic disc swelling in papilledema, a unilateral optic disc swelling, where in papilledema the optic disc swelling is bilateral, and number two, there is increased intracranial pressure. So unilateral optic disc swelling and a bilateral swelling in papilledema. That's the difference. And what happens in papilledema? Both discs swell because of the pressure from above, from increased intracranial pressure. So what's a normal pressure, intracranial pressure? The normal pressure is about 7 to 15 millimeters of mercury, and at a pressure of more than 25, the alertness decreases, and if the pressure is more than between 40 to 50 millimeters of mercury, the cerebral perfusion decreases. That leads to loss of consciousness. And how intracranial pressure is measured definitely by transducer placed in the brain. And how to decrease intracranial pressure? A catheter surgically inserted into the lateral ventricles to drain the CSF. So the features in the papilledema may be acute state of papilledema and chronic. In acute state of papilledema, there are hemorrhages, exudates, and venous engorgement, cotton wool exudates, hyperemia. In acute stages, if there is acutely developing papilledema, the margins become blurred, blurring and elevation of the optic margin and enlargement of the blind spot. So acute papilledema causes central visual loss. Otherwise, the chronic one doesn't. It causes peripheral visual loss. So what happens in chronic? In different stages. First stage is that there is an incomplete C-shaped halo around the optic disc. C-shape is incomplete at temporal border, and there is obscurations of the nasal border. Okay, so this is in the first stage. Stage 2, the C-shaped halo, the grayish halo, is complete. It also covers the temporal area. There is nasal elevation, obscuration, and temporal is obscuration as well. So it's in the chronic stage, in the stage 1, C-shaped incomplete halo at the temporal side, and with the nasal border obscurations. And in the second stage, the C-shaped halo becomes complete, also covering the temporal border, and there is temporal excavation as well, elevation. Then stage 3, elevation of these borders, and there is optic nerve head elevation, enlargement, and at the disc margins there may be partial obscuration of the blood vessel leaving the disc. This is in the stage 3 along with the other features of stage 1 and 2. And then in stage 4 there is definite obscuration of at least one border leaving the optic disc here. Stage 3, all these features plus partial obscuration of one or more blood vessels, and stage 4, complete obscuration of one blood vessel leaving the optic disc. And then stage 5, dome-shaped elevation of the optic nerve head here, dome-shaped elevation in stage 5. And see this beautiful, this is known as star macula, and this occurs in neuroretinitis in cat's scratch, but it may also occur in papilledema and diabetic and hypertensive retinopathy. Star appearance of macula is due to leakage of lipid. These are the 4 stages of the papilledema. Stage 1, incomplete C-shaped halo, temporal side normal, but in stage 2, the C-shaped grayish halo is complete, also covering temporal side, and there is obscuration of the temporal side. Stage 3, there is obscurations of the blood vessels leaving the optic disc here, partial obscuration. Stage 4, complete obscuration of at least one blood vessel leaving this is optic disc margin here, leaving that. And then we have star appearance, not clinical features of the papilledema. It may be asymptomatic or may have headache, peripheral loss of vision. It may cause tunnel vision. So what about the disorders causing tunnel visions? Like this tunnel vision here, and maybe pigmentary degeneration of the retina. So this is the first layer. It causes the pigmentary degeneration of the retina, also causes tunnel vision, and also the drugs, antipsychotic and hallucinogenic drugs, lithium and especially thyroidazone, may also cause tunnel vision. Okay, we want clinical features. Tunnel vision, the dim vision, disturbed vision, decreased color vision, all these features in papilledema. But remember, acute papilledema, there is central loss of vision. Central loss of vision is a feature of optic neuritis, whereas papilledema causes normally tunnel vision. Now, causes of papilledema: trauma, tumor, infection, increase CSF production, decrease CSF absorption. Which vitamin axis causes papilledema? It's vitamin A axis that causes papilledema. Vitamin B12 deficiency causes papilledema. In which antibiotics? Tetracycline may cause it. And I've already told that lithium and thiazide may also cause papilledema. So investigations in the papilledema. Next topic, lumbar puncture. If there is a space occupying the unit, lumbar puncture should not be done because it may cause brain herniation. Ultrasound, B-scan, bright scan to detect drusen. We'll discuss drusen later because that occurs in AMD, adult macular degeneration. Fluorescent angiography, then fundus autofluorescence. We'll discuss it now. And optical coherence tomography. So we discuss B-scan, we discuss LP, B-scan for drusen. Fluorescent angiography tells you the extent of the vascular involvement. It is also effective in diabetic retinopathy, macular degeneration, and a contraindication to fluorescence is hypersensitivity, MRI and CT. MRI, magnetic resonance venogram, MRI are very important because they detect papilledema before it's visible in ophthalmoscopy. So what are the MRI features in papilledema? Number one, there is flattening of the posterior sclera, widening of the sheath, tortuosity of the optic nerves. So these are the features, that flattening of the posterior sclera already, and protrusion of the optic disc head, tortuosity of the optic nerve, widening of the optic nerve sheath. These are the features that you see from MRI before it detects any changes on direct fundoscopy or ophthalmoscopy. And high resolution MRI may differentiate papilledema from other neuropathies. And next is fundus autofluorescence. What is this? Fundus autofluorescence is a non-invasive procedure that detects the cellular products in descent disorders. This is autofluorescence. That lipofuscin is extruded out and it is detected by fundus autofluorescence. Then comes the optical coherence tomography. It determines the structural damage. It detects the thickening of the retinal nerve fiber layer, RNFL. How is the retinal nerve fiber layer thickness in papilledema? Yeah, the thickness is increased. Retinal nerve fiber layer thickness is increased in papilledema, whereas it's decreased in the neuritis or other conditions. So why is it increased in papilledema? The retinal nerve fiber layer is increased in papilledema because of the edema of the axon of the ganglion cell layer, axonal edema, and thinning due to atrophy in other conditions. OCT can also be very useful in AMD. In AMD also we can have some increase in retinal nerve fiber thickness layer, and it also detects OCT tomography, also detects glaucoma, retinal detachment, diabetic retinopathy. So these can be detected by OCT. Then there is a Heidelberg retinal tomography for 3D. Nerve fiber analyzer measures also retinal nerve fiber layer thickness. Now we have to compare this papilledema with the pseudo papilledema and pseudo tumor cerebri. So what happens in papilledema? With bilateral optic disc swelling with increased intracranial pressure. But with pseudo papilledema, there is bilateral optic disc swelling without increase in intracranial pressure. Both optic discs are swollen in pseudo papilledema, but the intracranial pressure is normal. And what condition is that? That's AMD. See, this is adult macular degeneration. We have drusen here, which are detected on B-scan. See, they are fluorescent, hyperlucent, calcified hyaline bodies from the cells, and see this very white, chalky white optic cup, clear margins. But in papilledema, the optic disc is blurred. It's raised over the surface. The margins are not clear. But in pseudopapilledema, there are clear margins and optic disc is white, whereas it's blurred in papilledema compared to pseudopapilledema. And this one, drusen, where does it occur? It's clustered in the macula, scattered all over, but it occurs in non-exudative form of AMD, which is more common. That occurs in 85% of cases. So this is pseudopapilledema. This is Trusen here, and this is blurred margin, optic cupping, so everything of that papilledema has. So that's the difference between the pseudopapilledema and papilledema. Then we come to the pseudotumor cerebri. So what happens in pseudotumor cerebri? Pseudotumor cerebri, there is bilateral optic swelling also, and increased intracranial pressure also. Both conditions meet with papilledema. So bilateral optic swelling with increased intracranial pressure. Its other name is idiopathic intracranial hypertension. But the CSF is normal. Pressure is more, but there is no other abnormality in CSF except that CSF pressure is increased. So that's pseudotumor cerebri. This occurs in young, obese, female, and it may occur due to poor absorption of CSF. There are certain drugs that may cause it. Vitamin A toxicity, tetracycline antibiotic, phenothiazines may also cause pseudotumor cerebri. Steroid withdrawal may also cause quinolones, nalidixic acid. The treatment is acetazolamide for the pseudotumor cerebri that decreases the CSF production, and reduce weight, reduce salt intake, and for the non-responders, it's a shunt to be placed there. So we did the papilledema, pseudopapilledema compared with this is with bilateral optic swelling without increasing in rise in intracranial pressure. Pseudotumor cerebri, that one here, with increased intracranial pressure, but CSF was normal.